Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 215 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, PCA, a 51-year-old man presented with several months of rapidly progressive cognitive decline and new-onset tremors. PCA was previously healthy and has no family history of neurocognitive disorders. 4 months ago, PCA was able to work and function normally. PCA has had behavioral changes and memory impairment, and most recently has started to have gait instability and tremors. EEG showed periodic sharp waves and T2-weighted MRI showed increased activity in both thalamic nuclei. A lumbar puncture was performed and routine tests were ordered. So my question to you is, which non-routine study would you consider adding to help elucidate the most likely diagnosis? Would it be A. cryptococcal antigen, or B. culture for acid-fast bacilli, or C. cytology, or D. HSV-PCR, or would it be E. immunoassay for 14-3-3 protein? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. immunoassay for 14-3-3 protein. I will justify why. This patient likely has Creutzfeldt-Jakob disease, abbreviated as CJD. He has had rapidly progressive cognitive decline with extrapyramidal symptoms. Classic EEG pattern with CJD includes periodic sharp wave activity. Brain MRI showed the pulvinar sign, with increased thalamic activity bilaterally. Elevated levels of 14-3-3 protein in the CSF would be supportive of a diagnosis of CJD, though it can be elevated in a variety of other conditions, including other viral encephalitides and stroke. Please advance to the next question. Pause the video at this stage and closely scrutinize the photo below before answering the next question. My next question to you is, which of the routine childhood vaccinations listed below has led to a radical shift of the epidemiology for the condition depicted by this radiograph? Is it A. DTaP, or B. HIV, or C. IPV, or D. MMR, or is it EPCV? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. HIV. I will explain why. The photograph shows the thumb sign with edema of the epiglottis suggestive of epiglottitis. Haemophilus influenza type B, abbreviated as HIV, caused most cases of epiglottitis prior to adoption of routine vaccination against this organism. Incidence of and mortality rates from epiglottitis have diminished significantly because of the vaccine, and now most cases are caused by non-typable Haemophilus strains. Please progress to the next question. HCA, a 2-year-old girl is brought to the emergency department with 1 to 2 days of low-grade fevers, cough and progressive shortness of breath. Inspiratory stridor is noted on examination. Neck radiograph is shown below. Pause the video at this stage and carefully scrutinize the photo in this slide before progressing to the next slide. So my question to you is, what is the most likely cause of HCA's symptoms? Is it A. Haemophilus influenza, or B. human metapneumovirus, or C. influenza, or D. parainfluenza, or is it E. respiratory syncytial virus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Parainfluenza. I will clarify why. The radiograph depicts the steeple sign with narrowing of the trachea, consistent with croup. Croup is most commonly caused by parainfluenza. Various other causes of croup include influenza, RSV, metapneumovirus, adenovirus, rhinovirus and enterovirus. Please progress to the next question. And the next question reads, FCL, a 9-year-old girl presented to her primary care physician's office with several days of fever and sore throat. FCL had tender, cervical lymphadenopathy and evident exudates on her tonsils. Pause the video at this stage, and carefully scrutinize the photo in this slide before answering the next question. The organism that is the most likely cause of FCL's symptoms can also cause all but which of the following? Is it A. glomerulonephritis, or B. mononucleosis, or C. rheumatic heart disease, or D. scarlet fever, or is it E. toxic shock syndrome? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. mononucleosis. I will clarify why. This patient has exudative pharyngitis, most likely from Streptococcus pyogenes. Group A, streptococcal infections can be associated with scarlet fever, post-streptococcal glomerulonephritis, rheumatic fever and toxic shock syndrome. Epstein-Barr virus is the most common cause of mononucleosis and can cause an exudative pharyngitis, but is less likely in a 9-year-old. Please proceed to the next question. And the next question reads, HPI, a 75-year-old man was admitted from his nursing home with several days of fever, non-productive cough, headache and diarrhea. The nursing staff mentioned that 2 other patients had also been unwell and had had fevers and respiratory symptoms. On admission, HPI had a body temperature of 38.5 degrees Celsius, a pulse of 110 beats per minute, a blood pressure of 98 systolic 50 diastolic and oxygen saturation of 89% on room air. HPI's initial laboratory evaluation was notable for a sodium of 125 milliequivalents per liter, creatinine of 1.6 mg per deciliter, and white blood cell count of 16,000. His chest radiograph showed bilateral, diffuse, interstitial, pulmonary opacities. Cultures were ordered and broad-spectrum antibiotic therapy was initiated. Of the listed antibacterials below, which of the following would be most likely to be effective against the causative pathogen? Would it be A. amoxicillin, or B. azithromycin, or C. ceftriaxone, or D. clindamycin, or would it be E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Azithromycin. I will explain why. HPI is presenting with a syndrome compatible with atypical pneumonia. It is also noteworthy that there was a cluster of sick patients at his nursing home, which could be suggestive of a spreading respiratory viral infection, or Legionella, which has been associated with hospital and nursing home-related outbreaks because of contaminated water sources. Hyponatremia, acute renal failure, abnormal liver function tests and gastrointestinal symptoms may be seen with Legionellosis. Other causes of atypical pneumonia can include Mycoplasma pneumoniae and Chlamydia pneumoniae, which can also be treated with azithromycin. Please progress to the next question. And the next question reads, first-line antibiotic regimens for adults with suspected community-acquired pneumonia include all but which of the following? Is it A. Amoxicillin clavulinate, or B. ceftriaxone plus azithromycin, or C. doxycycline, or D. moxifloxacin, or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. vancomycin. I will explain why. Recommendations suggest that initial antibiotic therapy should include durable coverage for Streptococcus pneumoniae with consideration of additional pathogens based on specific clinical situations. Choice of intravenous versus oral therapy depends on severity of illness, and for more severe disease, monotherapy should not be administered. Please progress to the next question. And the next question reads, HTP, a patient who was recently treated for influenza returns to the hospital complaining of fever, productive cough and pleuritic chest pain. She completed a course of oseltamivir for influenza and was feeling better when she left the hospital. HTP now has had worsening fevers, with cough productive of purulent sputum and right-sided pleuritic chest pain. HTP's chest radiograph showed right lower lobe pneumonia with areas of cavitation. HTP is started on antibiotics. So my question to you reads, which of the following drugs would be least likely to be effective in HTP's clinical scenario? Would it be A. ceftaroline, or B. daptomycin, or C. linezolid, or D. telavancin, or would it be E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. daptomycin. I will justify why. This patient has post-influenza pneumonia, which is most commonly caused by Staphylococcus aureus. All of the listed drugs could be reasonable antibiotic choices, except for daptomycin. Daptomycin is inactivated by pulmonary surfactant and should not be used for treatment of pulmonary infections. Please proceed to the next question. And the next question reads, PNF, is a 50-year-old patient admitted with STEMI now status post-CABG, and with a complicated hospital course thereafter. It included prolonged respiratory failure requiring tracheostomy and gastrostomy tube placements. PNF also received several days of broad-spectrum antibiotics postoperatively because of shock, and concern for possible sepsis. PNF is now having increasing supplemental oxygen requirement and fever. PNF's chest radiograph shows diffuse pulmonary opacities, worst in the right lower lobe. PNF's nurse also has noted increasingly profuse and purulent tracheal secretions. PNF was started on linezolid and meropenem, but, after 2 days, he was still having fevers and his respiratory status continued to worsen. PNF's tracheal aspirate culture is now growing an organism that was identified as an oxidase-positive, non-fermenting gram-negative bacillus. So my question to you is, what is the most likely cause of PNF's symptoms? Is it A. Burkholderia cepacia, or B. Citrobacter freundii, or C. Escherichia coli, or D. Serratia marchescens? Or is it E. Stenotrophomonas multifila? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Stenotrophomonas multifila. I will explain why. PNF has hospital-acquired pneumonia and did not demonstrate clinical improvement on broad-spectrum antibiotic therapy. He has multiple risk factors for development of drug-resistant pathogens, including his prolonged ICU stay and antecedent antibiotic therapy. Linezolid and meropenem would provide more than adequate activity against most gram-positive and gram-negative pathogens, including those that would produce extended-spectrum beta-lactamases. Stenotrophomonas can be a cause of HAP, is intrinsically resistant to the antibiotic agents that he has been receiving and is a non-fermenting gram-negative bacillus that is oxidase-positive. Other non-fermenting, oxidase-positive gram-negative bacilli include Pseudomonas, Acinetobacter, Achromobacter and Burkholderia, among others. Please proceed to the next question. And the next question reads, NOP, a 50-year-old man who recently emigrated from India is admitted for debridement of a diabetic foot ulcer. NOP's preoperative chest radiograph incidentally showed right upper lobe cavitary disease. NOP has been a cigarette smoker for 30 years and has a chronic, productive cough, but is not short of breath, and has not had fevers, night sweats, or weight changes. NOP had BCG vaccination when he was a child. His tuberculin skin test was positive at 12 mm of induration. The next steps in NOP's management should include all but which of the following? Is it A. Airborne isolation with N95 respirators and negative pressure ventilation? Or B. CT scan of the chest? Or C. HIV antibody testing? Or D. Sputum collection for acid-fast bacilli stain and culture? Or is it E. Treatment with isoniazid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Treatment with isoniazid. I will clarify why. This patient has findings concerning for possible active pulmonary tuberculosis. He has some symptoms, but none so severe that he mandates urgent initiation of therapy before a diagnosis can be made. His tuberculin skin test was positive, but that could be reflective of his previous BCG vaccination. While awaiting additional diagnostic workup, isolation measures are important to prevent possible transmission of TB. If active TB infection is identified, isoniazid monotherapy would not be appropriate and could provoke development of resistance. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 216.